Okay, so next is kidney stones. So kidney stones is actually pretty simple. It's just a lot of learning, so you don't need to worry about that. But you know how the patient will be presenting is that if there's an obstructed stone, there will be unilateral flank tenderness, colicky pain, which will be radiating to the groin, and then there can be hematuria, right? So what what's the first thing that comes to your mind with these symptoms is like the first thing in management is the non-contrast CT. You must go for a non-contrast CT in like everyone except for pregnant women, then you go for ultrasound. Okay, so just remember this part, non-contrast CT. So let's start with like there are four types of kidney stones. There's calcium, there's ammonium magnesium phosphate, there's uric acid, and then there's cysteine, right? So what you need to learn is that the pH, right, of the urine, and the how it's precipitating, how it's being managed, and of course the causes. So let's start with the urine crystal shape, which honestly I always mess up, but you can try it. For calcium stones, okay, so the first thing that you need to know is that calcium stones are the most common ones. Okay, and calcium oxalate are more common than calcium phosphate. And calcium oxalate, so think oxaluric acid, so it's like pH less, it's more acidic, it's towards acidic, and hypocitrate precipitates the calcium oxalate crystals. So what you need to know is that it is the causes can be ethylene glycol, ingestion, vitamin C, overuse, hypocitrate which precipitates, right, because it's usually associated with decreased urine pH, like I just told you. And then malabsorption, I think I discussed this before, how in like Crohn's disease there's malabsorption, so all the oxalate is like, what should I do? So I should just probably precipitate and form stones in the kidney, right? So how do you treat it? You treat it with thiazide, citrate, and then low sodium diet. So one thing I really need you all to like understand is that in calcium stones, like calcium oxalate stones, you do not limit or you do not ask the patient to stop using calcium or like calcium intake, because if there's no calcium, then the oxalate is free, right? There's nothing to bind the oxalate, so it will further precipitate the stones. So you do not ask the patient to limit calcium dietary intake, but you do treat it with thiazide, citrates, and a low sodium diet. That should do it. Then we have the calcium phosphate. So calcium phosphate is basically more towards alkaline pH, that will precipitate the stones, and it's wedge shaped, and you need to treat it with low sodium diet and thiazides, right? So citrate has nothing to do over here. I think citrate has chelating property. I'm not sure about this. You can check it, but that's why you use citrate in calcium oxalate stones, but no citrate in calcium phosphate stones. So up next is ammonium magnesium phosphate. For ammonium magnesium phosphate, I learned it like it's a mega problem, because normally you can simply remove the stone with like surgery or give thiazides, to flush it all out, but it's a mega problem. You need to treat the underlying infection in order to treat the ammonium magnesium phosphate stones. So it's also called screw white stones, by the way. So it's and I think it's pretty obvious. These are basically urease positive bugs that are causing these stones. So it's urease, so it's alkaline pH that's going to precipitate it. This accounts for 15% of the stones. It's caused by the infection with Proteus mirabilis, Staphylococcus saprophyticus, and Klebsiella. You really need to learn this, and I think we discussed it in class with Dr. Tahira as well. So Baki, it's simple. The urea